stroke is the leading cause of disabilities in the United States. The goal is prevention. Hypertension is a primary risk factor, among other things. However, hypertension, patients, you will ask physicians and they will say, it's that whole hypertension monitoring and things like that. Blood pressure, patients come in, go to the doctor, that white coat scenario, their blood pressure goes up. But what happens when they're at home? So it needs to be monitored for about 2 weeks before they can truly get diagnosed with hypertension. The goal is to prevent this stroke or cerebral vascular injuries that occur from strokes as a whole. Prevention, the non-modifiable risk, are also there as a whole. Diabetes, obesity, all that plays a role as well. Two different really types of our strokes in the world is they consider it a brain attack. There is ischemic and hemorrhagic. Keep in mind, the ischemic is just like a clot in the MI, that remember that tissue that is not getting blood flow because of that blockage. Same thing with the brain. If that brain tissue is not getting blood flow, it becomes ischemic. So that's where the ischemia comes in. If it's hemorrhagic, that means that there's blood on the brain. Okay? So again, longer disability time, more residual injury that comes from that. With the ischemia, with a patient who has the onset of stroke-like symptoms, within 10 minutes, they should be getting a CAT scan to rule out ischemic stroke. We can fix that quick by giving TPA or the thrombolytic therapy. But we have to make sure that it is truly a blockage or a clot causing that stroke and those stroke-like symptoms. We know the stroke-like symptoms, right? What are they? One-sided weakness. What?
Facial droop.
Facial droop. What else? Decreased sensation. Huh?
Like speech.
Speech. Either whether it's expressive or receptive. They don't understand what you're saying and they can't get the words out. What else? Thinking of the NIH scale, stroke scale, which should be a copy in Canvas for you as well. They're not able to recognize common things. That's an alder. Their vision fields are disrupted. What else?
Like severe headache.
Severe headache is usually what they complain of first before the symptoms onset. Okay, so looking at that, the reasons or the types of ischemic strokes, you don't have to memorize them. Just know, again, within that 10 minutes, we need to find out if it is an ischemic stroke to give thrombolytic therapy. Sudden headache, we mentioned. All of these other symptoms we mentioned. When it comes to terms, make sure you review those. We have the hemiplegia, the paralysis on one side. Paralysis on one side. The hemiparesis, number 2, is weakness on one side. The third bullet, I have this on a daily basis, difficulty forming words. Dysarthria. So difficulty forming words. The aphasia, expressive or receptive, that means they can't get the words out or they don't understand what's coming in. So expressive and receptive. The next one is your loss of vision, of visual fields. And the next bullet that should be added there is the inability to recognize common objects. That's where the pictures come in on that NIH stroke scale, where a glove, a key, a hammock, a cactus, and they're not able to recognize. Okay, so just some terms. TIA, transient ischemic attack. That's what lay people know as the mini stroke. This is actually a warning sign for impending bigger problems, where it could be because of blood pressure, where they have slight symptoms of what we mentioned earlier, but they don't stick around. That could be a warning sign for something bigger going to happen. One of the things is they need to get worked up to see why they're having these TIAs. It's not normal to have TIAs. One of the things they will do is the carotid Doppler mentioned, transcranial Dopplers, things like that. Then they find out that there's blockages in the carotid arteries. Keep in mind, if the coronary arteries can get blocked, and any other artery or vein for that matter, so can the carotids. So that affects blood flow. Maybe there's a piece of plaque or a small blockage or a clot that has traveled to the brain that leads to bigger problems when it comes to that ischemic stroke. So preventative therapy and treatment. Here is the carotid endarterectomy. That's removal of that plaque, clearing out those carotids. Then you'll see the anticoagulant therapy, antiplatelet, the statins, and then of course medications to control that blood pressure for those warning signs. Patients can have TIAs forever and never have a full-blown CVA. However, because they've probably gotten treated, let's hope, right? And so it doesn't lead into anything bigger. So definitely have to be some that we truly, truly can help. So 3 hours from the onset of symptoms, if it is truly an ischemic stroke, they can have their TPA or their thrombolytic therapy. Contraindicated for those patients that are having any bleeding disorders. Peptic ulcer disease is one that is a bleeding disorder or could potentially lead to a bleeding, but any bleeding disorders associated with the patient bleeding. Keep in mind, once we use thrombolytic therapy, the patient is more susceptible to hemorrhage as a big, huge side effect, and then cardiovascular collapse can also happen from the use of the thrombolytic therapies. It has to be an ischemic stroke though. Keep that in mind. Hemorrhagic stroke, again, the brain is exposed to the blood, and then it messes with the brain metabolism. So ICP increases due to blood in the cerebroid space. That ends up what has a bigger explosion per se. They usually complain of an exploding headache when it comes to their hemorrhagic strokes. Loss of consciousness in about 18 months for recovery for these patients with hemorrhagic. Medical management, CTs, bed rest, possibly sedation, all that goes along with that. So ischemic strokes in general, acute phase, and then the stroke is complete. The diagnoses that is associated with your strokes in general, ischemia specifically going back to that, blood flow, oxygenation getting to the brain, and pneumonia because of infection. All changes must be reported immediately if there's a change in a patient's LOC or any different types of signs or symptoms when it comes to patients with strokes. So can't stress that enough, and we've said it enough today. Probably will say it a couple more times as well. But frequent ongoing assessment, reporting any changing that is definitely needed. Complications listed there already, the goal, interventions, seizure precautions, and then that leads us to aneurysm precautions. A lot of times patients don't even know that they have aneurysms or a malformation in their brain until it's too late. A lot of times they don't have any predisposed or any symptoms associated with it. A lot of times you always hear of the patient having a headache going to bed, and then they don't wake up. And that malformation, that aneurysm then burst. So a couple of things is non-stimulating, if we are able to catch it early. Couple of things that happens too is non-stimulating stressful environment. Again, we're worried about that increase in ICP. Goes along with all those precautions with aneurysms. That really is for any patient that is neurological dysfunction. It's the same scenario with what we've mentioned before, but we try to catch it early if we can for sure with their symptoms. Questions about any of that?